Okay, so the next speaker is
Good
Bridget.
afternoon, everyone. Thank you for the warm welcome. My topic for today is problems faced in delivery of ketogenic diet.
So should I start?
Yes, please. Or you want me to first introduce Bridget? Okay, I'll just introduce her very briefly. So, Brijmeet is a dietitian. She is now working in Delhi and Gurgaon. She is in a private setting. She was working with us for many years and she's now there. She's very experienced. She has helped us conduct workshops also. So she has not just looked after patients, but she's also taught many of the dietitians who come here. So I think we can begin with a presentation. Brijmeet.
The private setting. As careful and meticulous as the planning of ketogenic diets, so is its implementation and delivery. Every detail has to be paid attention to and not overlooked to make the ketogenic diet a success. Now, what all can go wrong? The ketogenic diet was introduced in 1921. Ketogenic diet therapy requires a team approach. Most doctors feel that once they refer the person to a dietitian, their part of the job is over. Dietitians read up a few articles and books and start the ketogenic diet. And that's where literally everything can go wrong. In ketogenic diet, the doctor and dietitian have to work hand in hand. Now, here are some examples of how things can actually go wrong. Child on ketogenic diet since 4 months had no seizure reduction. Parents were about to give up the ketogenic diet and then they came to us as the last resort. We investigate why. And this is seen not just in one case, in many cases. Urine ketosis chart not maintained. Urine ketosis not checked 4 times a day. Enough emphasis not laid upon how important it is to get a urine ketosis of 160 mg per dl, which means 4 plus throughout the day. So when we checked the child's ketosis on arrival, his ketosis was merely 1 plus. With the parents, they were implementing the ketogenic diet, but the ketogenic diet was not being implemented in the perfect way, and that's why it showed no results. Another example of what all can go wrong. Child on the ketogenic diet since 3 months now refuses to eat food. Why? Dietitian has given 3 recipes to be used daily. Child rebels after few weeks and throws tantrums. He grabs food from other children in school. After we speak to the child and fashion recipes as per the child's likes and dislikes, we provide him with around 30 to 40 different choices. After dietary counseling of parents, child is given 6 different meals a day and now compliance is very good. Another example of what all can go wrong. Child of 6 months has been on the ketogenic diet for the past 6 months. Now he refuses to eat. Why? Because the dietitian has instructed parents to make 1 recipe a day and partition it into 6 meals and feed the child. Obviously, monotony in the diet, and that's why the child gave up eating altogether. After dietary counseling for parents, the child now accepts feeds with obviously greater variety in the diet. Okay, next is another example of what all can go wrong. Sometimes there are massive discrepancies in reporting of height for patients who stay outstation, for example. Now, the entire calculation of ketogenic diet depends upon the child's height and age, which is noted down or reported. So, discrepancies here can make a difference in the entire caloric calculation, and thereby that can affect the ketosis and thus the seizures. At times what happens is ratios and calories are fixed without the ideal body weight being taken into consideration by the dietitian. Ideal body weight should be calculated using 50th percentile of the ICMR chart. Improper calculation of ideal body weight will lead to incorrect caloric calculation, which will again thereby affect the ketosis and thus the seizure control. At times, children face lethargy and weakness on the ketogenic diet because the required or adequate dosage of supplements are not given to them. When children on ketogenic diet are unwell, pediatricians are seen giving dispersible tablets to children And that's what they even tell the parent, this much of sugar is not going to make any difference to the child. But we've actually seen this, even a gram of sugar can actually cause the ketosis fall flat to zero at times and thereby impact the seizures. Sometimes the baseline biochemical parameters are not checked or taken into consideration by doctors and dietitians. Running a panel of the essential blood tests is crucial for the success of ketogenic diet. So as while the seizures are being controlled, there are no side effects alongside. So for example, depending on the child's lipid profile, changes in oil type would have to be suggested at times. More on what all can go wrong. Dietitians do not realize that different brands of products have different nutritive values. For example, switching over from Amul cream to Vijaya cream will require the entire recipe to be recalculated. Otherwise, with the varying percentages of carbohydrate, protein, and fat in both types of cream, the ketosis can get affected. Sometimes parents as well do not inform dietitians and switch over brands without prior permission from the dietitian. Again, all this can affect the ketosis. Now coming to problems of setting up the ketogenic diet center in India. There is lack of awareness among medical practitioners, even neurologists. There's very low awareness in the general population that intractable epilepsy can be controlled by the ketogenic diet. There's long duration of counseling required for the ketogenic diet, including the demonstration of recipes, etc. There is still a dearth of well-trained dietitians for the ketogenic diet. There are definitely more places offering ketogenic diet for epilepsy today as compared to 5 years ago. However, errors continue to occur because in the ketogenic diet, the doctor and dietitian have to work hand in hand and then decide whether the calorie or ratio needs to be adjusted or medicine dosage needs to be adjusted. It is not a diet in which the doctor and dietitian can be functioning separately. So this is one of the prerequisites to make the ketogenic diet a success. There is poor patient and caregiver compliance. All these factors are an issue. Cost of food items, cost of investigation, cost of keto diet, cost of medications, problems in the family, lack of innovation, failure to add inappropriate spices, flavor, sugar-free substitute. Think about it. Even we wouldn't like to eat a bland diet, right? So since the ketogenic diet has to be implemented for at least 3 long years once it's begun, and sometimes even more depending on the seizure control time. So adding variety to the diet, adding different flavors to the diet is going to help make the diet more acceptable to the child. So just for example, if a child has milk, say a morning feed is milk, let it be 7 different flavors of milk on 7 different days. So it could be banana on Monday, strawberry on Tuesday, and say butterscotch on Wednesday. So the child will have a different flavored milk every day. That's going to keep him happy and going on the diet. And that's what we want for eventual seizure control. Only when the compliance is good, that's when we can follow the diet and then eventually attain the seizure control. Now, there could be problems outside the family, like meals at school and college, peer pressure, vacation, and social outings. All these pose problems to implementation of the ketogenic diet. So there's a multidisciplinary team required: a neurologist, dietitian, clinical psychologist, nurse for the blood test, EEG technician, physiotherapist, occupational therapist, and speech therapist. So even after the seizures are controlled, sometimes the body tone of the child may be very poor, sometimes the reflexes may be very poor. So that's where the therapists come in, and that's where they have to work. Equipments and other requirements for the ketogenic diet. So that's a demo kit. A demo kit generally has one digital weighing scale, measuring cups and spoons, non-stick cookware, and silicone spatulas. And these are the product samples which are used for the ketogenic diet. The keto diet stick for checking the ketones 4 times a day, soya milk, sugar-free natura pellets, and soya in different forms, which is soya powder, soya granules, soya rava, etc. Equipments and other requirements for the ketogenic diet. The EEG machine, digital weighing scale, measuring tape, standards weights for calibrations, desktop or laptop, printers, stationery, telephone and internet, exchange list for food items, AV aids and instruction manual for patient and caregiver education. All this material is required for training. Now, this is another place where errors can happen in the ketogenic diet. So, caregivers are taught how to use the weighing scale. So, that's how you press the start button and always check the unit. The unit should be in grams and not ounces because that's how the recipes are calculated. And changing the unit could give rise to gross problems. Okay, so after placing the measuring cup on the scale, then the tare button is pressed and then we start putting food in the weighing scale. So weighing scale inaccuracy could be another problem. That's why we have the weighing scale calibrations with us. We always keep a calibration of 100 grams and 200 grams. So every follow-up, the patient, caregiver are supposed to get their weighing scale and we get it checked. We get the calibration checked. Okay. More on what all can go wrong. Sometimes water is not boiled for 20 minutes and that could lead to infections, and infections could affect the ketosis and thereby the seizure control. Less water consumed could give rise to a concentrated urine and which would show as a false high ketosis, which may not be the real case. Same way, if there is overconsumption of water, it could lead to diluted urine and which would give us a false low ketosis. Although eventually the amount of water you have is not going to affect your blood ketosis, and eventually it's the blood ketosis which is going to control the seizures in the brain. But so parents, caregivers are advised that the urine color could be light yellow or pale yellow at all times. It should never be dark yellow, and having a transparent crystal clear color at all times could sometimes means over water intake, which could lead to a falsely low ketosis on the keto chart. And so thereby sometimes we have to check the blood ketones as well to correlate how much is the blood ketosis. Now, there could be problems sometimes with the list of vegetables and fruits. Not reading exchange list well for vegetables and fruits could lead to wrong choicing or wrong choices of the ingredient. So sometimes A group vegetables which are lower in carbohydrate are accidentally interchanged with B group vegetables which are higher in carbohydrate. All this can affect the ketosis and thereby the seizures. Sometimes there are problems with usage of eggs and chicken as well. There are common errors seen as caregivers use unbeaten eggs for weighing. Sometimes chicken is weighed along with the bone. All this is going to affect the ratio and the calories and thereby the seizure control. Sometimes there could be problem with the keto diastic as well. There could be confusion with the color that could lead to a wrong reading. Or sometimes exposure of the keto diastic to air for a long duration can lead to wrong readings. So what we do is every time the patient comes for a follow-up, we check his urinary ketosis using his keto diastic, and we use our keto diastic as well and ask him to check his ketosis. So we correlate the reading on both the keto diastics to ensure that the reading is correct. Now here is like a comprehensive list of all that we've discussed for now. Now all that can go wrong on the ketogenic diet. So the urine ketosis record charts are not maintained, or urine ketosis not being checked 4 times a day, or enough emphasis not laid upon why ketosis should be 4+ throughout the day. The standard recipe being fed to the child throughout the day, monotony in the diet, height discrepancies, errors in calculation of ideal body weight or calories, required supplements not being given to the child, disposable tablets being allowed, weighing scale inaccuracy, vegetables, fruits, chicken or eggs not being weighed in the correct manner, oil combination not being followed appropriately, cost of food products or keto diastic could be issues at all sometimes. So this is a comprehensive list of what all can go wrong while implementing the ketogenic diet. So all these things should be taken into consideration and should be taken care of while implementing the diet. Thank you.
Yeah, thank you very much. That was a very comprehensive but very important, very important points. They may seem small, but that's very important for us to ultimately get compliance and therefore improvement. If you don't have compliance, if you cannot uh, deliver the diet that the child wants, you're going to fail. So that was excellently done. And the next speaker is none other than Dr. Tipu Sultan from Lahore. He's done a lot of his education post MBBS in the UK. In various, I mean, been in so many institutions in the UK that I don't want to go through all of them, but he's been a lecturer, he's done his fellowship over there, etc., etc. So his publications are immense. So even that is very difficult to go through because there's so many of them. Publications and presentations, and he's been all over. So I think the best is let's let Dr. Tipu Sultan speak to us on a very important topic also. What are the complementary roles of the doctor and the dietitian? Because without that, you are not going to get the best results. Over to you, Dr. Tipu Sultan.
Thank you, Dr. Janak, for your kind words and the introduction. Sorry for my bad sore throat, but I will try my level best to speak as loud as possible, which may be audible everywhere across Southeast Asia.
Yeah, Dr. Tipu, we are going to play your video. We have the entire thing. So you don't have to worry about your voice. Okay?
So if it is possible,
yes, it is absolutely possible. So you could, you don't share screen. We'll do it.
So
yeah, you can go on.
Good afternoon everywhere across
Stop
Southeast Asia.
sharing screen.
Okay.
Tipu, stop sharing screen, please. So we'll do it from here and it will go well. Good.
Thank you. Bismillahirrahmanirrahim. A very good morning, everybody all across Southeast Asia and globally. First of all, I would like to thank Dr. Janak and all the colleagues from ILAE to organize this very important topic for the management of drug-resistant epilepsies and beyond about the ketogenic diet. So I'm not a keto expert, but still I would like to share my experience and a couple of slides about the complementary role of doctor and the dietitian. This is the Department of Pediatric Neurology, Children's Hospital and University of Child Health Sciences. And the purple color balloons are actually representing the Purple Day. The picture was taken during one of the Epilepsy Day, which was usually celebrated in the month of February every year, and the Purple Day traditionally in the month of March. So the picture was taken during one of the International Epilepsy Day. So we used to have a public awareness seminar during these days and gather families who have actually suffering children with epilepsy and those who have completed their treatment, and they share experience for the other parents. So quickly, I'll move to the topic, which is ketogenic diet, and give you just a bit of insight about the keto and then come to the actual topic. So keto is, as you are already familiar during the previous talks, is a high fat, adequate protein and low carbohydrate diet. And Actually, it induces nutritional ketosis by changing the proportion of glucose and fat. So, by definition, keto diet modulates inflammation, control the balance between the pro and antioxidant process, and alter the composition of the gut microbiome. History dates back up to before Christ and Hippocrates' time. So, however, at that time, people strongly believed that starvation led to cessation of seizures. And though there was not actual record available, but experience was available from the old data. However, formal data about the recent data about the keto was from 1921, when first time it was actually experienced in the management of drug-resistant epilepsies or per se epilepsies. Subsequently, in the later half of the last century, MCT was created and a commercial formula was established. And in the 21st century, use of ketogenic diet in children, in infants, and even in pregnant women were established. So this is the actual area of evolution for the ketogenic diet. And now it has well been established that keto is a perhaps modality of choice for all neonatal epileptic encephalopathies, epileptic syndromes, and in general, drug-resistant epilepsies in older children. So, though the workshop is primarily designed for children with drug-resistant epilepsy or epilepsy, however, the spectrum is quite broad. It is helpful not only for the epilepsies, but also for migraine, Alzheimer's disease, Parkinson's disease, as well as for depression. There are different types, which includes classic keto, medium chain, modified Atkins, and low glycemic index treatment. And the proportion of fats, proteins, and carbohydrate varies from type to type. And it is well evident in this pie chart. So, coming to my topic or theme, these are the points I would like to highlight in the next few minutes. So, as the topic or theme was collaboration between the doctor and the dietitian. So, it's DD. I'm sure many of the residents were among the audience list. So DD is differential diagnosis for the resident or for the physicians. So again, it's a DD, doctor and a dietitian. So for the DD, this pair of DD, that for this theme, the points they should address are patient selection, which is perhaps the most important, followed by pre-ketogenic diet counseling and evaluation, dietary choice, implementation and supplementation, follow-up, of course, side effect monitorings, and the most important, anti-epileptic drug adjustment. After the implementation of ketogenic diet, how one can reduce or modify the past combination of anti-epileptic drugs, and last but not the least is ketogenic diet discontinuation. So the first theme is selection. Though the indication is quite broad, but there are certain syndromes in which keto diet is perhaps the modality of choice. And these include GLUT1 deficiency, pyruvate dehydrogenase deficiency, complex 1 mitochondrial disorders, the most common and commonly taken by the neurologist or the pediatric neurologist as a challenge is tuberous sclerosis complex. And as I mentioned in my initial slides, epileptic encephalopathies, infantile spasm, fires. Professor Shahnaz Ibrahim from AKU Karachi, Pakistan, to speak on fires and super refractory status in her talk. But there are certain contraindications, which are, some of them are absolute and few of them are relative. And these are carnitine deficiency, long chain hydroxyl-CoA deficiency, porphyria, etc. So one should not consider them as an area where keto may be tried. So pre-KD counseling and evaluation is again very important thing. So clinic visit to identify seizure type, etiology, current medication, and all these points have to be addressed during the pre-KD counseling and evaluation. And let me clear my young colleagues and KDs, this is perhaps the most important and challenging thing to do, because it's really difficult in countries and areas and the region like Southeast Asia and Pakistan, where milk and the carbohydrates are the staple food for many of us. So it's really challenging to guide them to avoid carbs from the infants or neonatal nutrition. So I believe one should spend more time on this pre-KD counseling and evaluation. Of course, assessment is really important. And I believe as I start my talk from the combo of DT, doctor and the dietitian, all these things, points, should have been done in joint session. Many years back, when I was doing my training in Glasgow, even in neuromuscular clinic, we are a group of 7 or 8 people, including psychologist, social worker, community worker, fellows, physician, consultant, nurse, etc. So I believe the combo of DD may be even broadened, and one may include a psychologist or social worker, of course, a keto nurse, etc. So this pre-KD assessment is equally important, and one should take care of all these points before the actual institution of KD diet. So here is the list of some blood investigation, imaging in selected cases, ECG, EEG, of course, and to exclude any underlying metabolic disorder, urine organic acid and plasma amino acids. And if you are still sure that you are dealing right child for the keto diet therapy, then you may proceed. I think again, the choice, as I mentioned before, classic keto or modified Atkins or low glycemic index, again, is really important to begin with. And again, it should be a joint decision between the DD as well as the family and the, of course, in particularly in case of grown-up child. And it varies from patient to patient. Selection varies from patient to patient. Calculation is primarily done by our colleagues, our dietitian, and I believe they would give you more detail about this nitty-gritty of diet plan as well as the calculation. So I would not go into the details. Implementation is really challenging, particularly long-term implementation. And apart from this combo of DD, I believe one should always add moms and maybe the grandmoms, because in Southeast Asian culture, where giant families are the norms, grandmoms have a significant impact on the child's growth and development and the selection of food and day-to-day activities. So I would strongly recommend to my young pediatric neurologist as well as the dietitian involve the families. So this DD should always involve the families. Supplementation is, of course, really important, and primarily it's the domain of the physician. So micro and macronutrient deficiency may be associated with ketogenic diet, and one may monitor and add all these nutrients right from the start. Generally, constipation is a challenge in majority of children and adolescents, so maybe a laxative may be added right from the start. Follow-up is, of course, one of the most important point. Generally, we recommend a follow-up initially monthly, and in the third month, from the third month, it should be particularly for those cases where seizures are reasonably controlled and ketogenic diet adjustable at 3, 6, and 9 months, and then at a year. After 1 year of KD, visit may be spaced out even up to 6 months, or keeping in view the last 2.5 year COVID experience through email, maybe telephone or WhatsApp consult or kind of online consult. So I would strongly recommend these use of these gadgets and these online consult for all those families who are from the far-flung areas, because of this financial crumbed situation globally and in the region. It's not really easy for the families to travel for hundreds of miles and spend thousands of rupees, not only on the diet, but also on the traveling. So I strongly recommend follow-up should have been individualized depending upon the family's social, financial circumstances and the travel time and the cost. So follow-up should include all these assessments, which include, of course, height, weight, and BMI, head circumference, and of course, assessment of the micro and as well as the macronutrient deficiencies, adjustment if at all required, and medical evaluation. The fundamental point would be about the anti-epileptic drugs, their side effect, are not only the side effects of the ketogenic diet, but also side effects of the anti-epileptic drugs. So which is perhaps most important. And some blood sampling for the monitoring of some of the anti-epileptic drugs like valproate sodium, and if required, any other investigation. So as I mentioned, few lab tests in the initial slides. During the follow-up visits, there are some blood investigation which may be required depending upon the individual circumstances, and one may select fewer investigation in a child depending upon the overall scenario. So probably again, the education is a must, whether it's pre-KD counseling, whether it's during KD, or whether it's after KD. Education is must. KD is yet not very popular in the pediatric neurology clinics, in the physicians' mindset. I believe there is a huge gap between the people who are actually using KD and majority of physicians or neurologists who are not well aware about the KD. So I will hats off to Janak for the region and Professor Shahnaz for Pakistan particularly, because their continuous advocacy regarding the KD. So advocacy is a must. So I think I strongly believe we should not only organize specific public awareness days for the KD, but also for the physicians to teach them, to train them, and to educate them. So I would share a couple of booklets developed by our unit in the subsequent slides. So concurrent anti-epileptic drugs management, as I mentioned in the previous slides, is really important. And I would again emphasize, at times there are change in the type of seizure, or at times rebound seizure phenomena occur rarely in children once they switch from only anti-epileptic drugs to combo of anti-epileptic as well as KD. Discontinuation is again very important point. So again, as I mentioned in many previous slides, it's again individualized depending upon the individual circumstances, but a rough guide is like this: 50% seizure reduction, one may discontinue after 2 years, and 90% seizure reduction with minimal side effects, KD, may be continued for several years. So in case of infantile spasm and status epilepticus, shorter duration of 6 months may be sufficient. Longer duration are required in case of GLUT1 deficiency. So there are definitely few challenges. This diet still require hospital admission most of the times to begin with. And we need to find ways to make these diet easier, accessible, cost effective. And more professional support required for the families, for the children. And I always believe a collaborative effort between these combo of DD as well as families. These are the books developed by our department and unit, not only for the epilepsy, its follow-up, its overall overview, and then specifically for the families on ketogenic diet. I will stop here with this picture of Children's Hospital and Institute of Childhood. Picture was taken about 2 decades ago at the inaugural ceremony of Children's Hospital, which was in 1998. And now this Children's Hospital has been upgraded to University of Child Health Sciences and Children's Hospital in Lahore, Pakistan. With those remarks, I will stop here, and I'm happy to answer any question if at all. Once again, thank you, Dr. Janak, ILAE, for giving me this opportunity to speak with you on this very important topic of ketogenic diet in drug-resistant epilepsies, a complementary role of physicians as well as dietitian. Thank you very much.
So thank you, Tipu.
Oh, thank you, Janak.
That was a very good session we had, and a good rounded off everything, so that all those who have been sitting through the day, they've got an idea of how to go about setting up their own centers. And now Dr. Natasha Ghani, young pediatric neurologist also from Lahore, who's been a pediatric neurologist for the last 4 years, is working with Dr. Tipu Sultan. She has many awards, many distinctions to her name. She is going to show us some case presentations, which I think is very, very important, because ultimately we learn from the patients. I always believe that. You can go to any number of conferences, workshops, books, read as much as you want online, but every patient is a challenge. So I'm sure she's going to show us some really beautiful cases from which we can learn a lot. So I urge all of you to remain. A few of you are leaving. No, this is where you're going to learn more than you learn throughout the day. So
good afternoon. Should I start, or starting the recording?
I am going to play your recording.
Okay. So I am muting my mic.
Yes, please be there for the Q&A session.
Okay, thank you. Good afternoon. And thank you, Dr. Janak Nathan, for giving me an opportunity to present few of our challenging and interesting cases. For this, I like to share my screen with you. I'm Dr. Natasha Kani, working as Assistant Professor Pediatric Neurology in University of Child Health Sciences and Children Hospital, Lahore, Pakistan. I'm also focal person of Ketogenic Diet from our university. Today, I will discuss few of the challenges we are facing with ketogenic diet in patients of drug-resistant epilepsy. Our case 1 is a 9-month-old male child with history of excessive irritability and disturbed sleep, which was followed by fits since 2.5 months of age. His fits were focal clonic and epileptic spasms having multiple episodes per day. He was a developmentally delayed child and has achieved partial neck folding till now. He cannot fix and follow. There was no social smile, and his hearing was also affected. He is our index child, in which you can appreciate the fits. He is having 50 chronic seizures involving the left lower limb and the left upper limb as well. You can see that the child is also having a pooling of eyes associated with these focal clonic seizures. The child is quite irritable, and his excessive irritability led his parents to bring the child to us. And this irritability was very disturbing for the family. His birth events were uneventful. He was born to related parents with history of one sibling death at 1 year of age, with similar history of developmental delay and drug-resistant epilepsy. On examination, the head circumference of my patient was 45 centimeter. He was hypotonic. His reflexes were elicitable with upgoing planters. His fundoscopic examination was normal, and there was no evidence of any dysmorphism or any cutaneous stigmata. There was no visceromegaly. During the course of illness, his fits were refractory to treatment, and he was having multiple admissions with refractory status epilepticus. Because of these refractory status epilepticus, he took multiple anti-seizure medications till the age of 9 months. He received vitracitam, carbamazepine, benzodiazepine, topiramate, phenobarbital, and oral prednisolone, but still having intractable seizures. So the child was investigated. His metabolic profile, including ABGs, NICAP, urinary ketones, serum amino acids, and serum lactate levels, were within normal limits. His serum amino acids and urinary organic acids also turned out to be normal. His MRI brain was showing hypomyelination with prominent extraventricular spaces. This MRI was done at about 12 months of age. His EEG was done before starting KD, which was showing generalized bursts of sharp and slow wave discharges with chaotic background. So we went for his genetic testing. His genetic testing showed SCN2A gene, which showed epileptic encephalopathy, as we were suspecting in this patient. Because of these refractory seizures, we plan to start KD in this patient. So the KD protocol was started while the child was admitted in neurology ward. His blood sugar and urinary ketones monitoring was done. The KD was started initially in the ratio of 2:1 and later on stepped up to 4:1 ratio. And the KD was started in July 2020. During the time in neurology ward, his mother was counseled regarding the preparation of diet and his monitoring of urinary and blood ketones, and the management and monitoring of any hypoglycemic episodes which can occur at home. The child was discharged once the ketosis was achieved and his mother was counseled. Response on KD is that the child is on our close follow-up since then. On every visit, we assess his anthropometric measures, dietary compliance, we check his keto diary, which is being maintained by his parents, regarding his blood and urinary ketones and any hypoglycemic episode. His urinary ketones are in 3 to 4 plus range and his blood ketone levels are 2.5 to 3 millimoles per liter. Response on KD is that his seizure burden is reduced to 70% and his motor functions are improved. His irritability has been settled. He is our index child. You can see that the child has achieved neck holding. He has achieved neck holding. The child is sitting with support and his irritability has been resolved. So the child cannot fix and follow, but his motor functions has improved. The hurdles we are facing on KD is that during the course on KD, he has 3 to 4 admissions because of the vomiting episodes, gastroesophageal reflux, and constipation. Currently, he is on 3 anti-epileptics, which includes levetiracetam, topiramate, and clonazepam. Still, the child is having mild irritability and subtle fits episodes, for which we are unable to wean him off the anti-epileptics. You can see that the child is on treatment and is still having these subtle episodes of seizures with upwelling of eyes. So the child, though these episodes are decreased in number, but whenever we start reducing the anti-epileptic drugs, the child again starts having these episodic upwelling of eyes, which are very much distressing for the parents, and we are unable to wean him off from these anti-seizure medications. Now, what should we do? The child is on KD for the last 2 years with good compliance. The main concerns of his 3 to 4 admissions are the child is having episodic metabolic acidosis. We want to know, is it due to KD? As we have to give him soda bicarb on every admission whenever he is having metabolic acidosis. The second is that the child is having anti-seizure medication dependent levetiracetam, benzodiazepine, and topiramate. Despite 2 years on KD, is it failure of KD that we are unable to wean him off from the anti-epileptics, or when should we wean it off KD? Should we wean the KD first and then later on the anti-seizure medication? Third query is, how should we treat severe constipation and regurgitation while the child is given multiple laxatives and anticoag treatment? This was all about our first case, and we were having most of the problems with the case one. Another case is a 13 years old male child. He was developmentally normal till he developed anoxic brain damage secondary to superrefractory status epilepticus. And for this purpose, he remained admitted in tertiary care hospital and being ventilated for a couple of days. He had a history of intractable fits since then, for which, and these fits were generalized tonic-clonic and drop attacks. He also developed behavioral issues, including aggressive behavior and cognitive decline. During the course of illness, he also took multiple anti-seizure medication, including levetiracetam, valproic acid, benzodiazepine, lacosamide, topiramate in maximum doses, but his fits were refractory to treatment, and he is on zonisamide and benzodiazepine. So we plan to start KD in this patient, and KD was started in July 2021, about a year ago. The child is improving on KD. His fits frequency is reduced to 70 to 80%. His cognition and behavioral issues are resolved. You can see our patient looking very happy. His behavioral issues and cognition has been improved, and the child has gained height, but the query is that his weight has significantly reduced over a period of 3 to 4 months. And now the current weight is 37 kg, as previously it was 53 kg. And it happened just over a period of 3 to 4 months, while the child is on KD for last 1 year. So our query is it due to KD? Another case is a 6-year-old male child with insignificant birth and family history. He was having intellectual disability with refractory seizures and cognitive delay. He experienced variable types of seizures, including generalized tonic-clonic and drop attacks with multiple episodes per day. Because of these refractory seizures, he also took multiple anti-seizure medications, including levetiracetam, valproic acid, benzodiazepine, lacosamide, topiramate in maximum doses. And currently, he is taking valproic acid and benzodiazepine. Because of these refractory seizures, we also started KD in this patient, and it was started in July 2021, about a year ago. And he was also doing well on ketogenic diet with reduction in seizures of 70 to 80%. He is good compliant to medication as well as to KD. His urinary and blood ketones are within the range of ketosis. His cognition and self-help has improved. But the query in that patient is that he has significantly gained weight over a period of 3 to 4 months. And now his current weight is 35 kg. Previously, his weight was 27 kg about 4 months before. So our query is that that gain weight is due to KD or due to the synergistic effect of KD and valproic acid, as the child is taking valproic acid, but he is taking it for the last 2 years. So and he has started gaining weight just over a period of 3 to 4 months. He is our index child. You can see when he presented to us at the time when we started his KD, he was about 27 kg. Now you can appreciate that he has just gained weight over a couple of months, and now the gained weight is our goal. Thank you. These were the queries which we were having regarding these cases. At the end, I like to introduce you to my keto team. We have a very dedicated team involving a nutritionist and keto staff. Our keto staff nurses are very helpful, and they are always being helpful in monitoring and giving social support to the mothers whenever they need it. And I have always been encouraged by and motivated by attending the lectures and workshops from Dr. Janak Nathan, and locally from Professor Shehnaz Ibrahim from Aga Khan University, Karachi, Pakistan. She has always been very helpful in giving support and helping us in managing these patients. We have just started the keto diet in a recent past, and it has all been possible because of the support, guidance, and encouragement by our professor, Dr. Tipu Sultan. Thank you, and welcome for listening.
Thank you, Dr. Natasha. Those were really very thought-provoking. So I think before I go to the others, I'm going to start with you first because those cases are in our mind right now.
Yeah.
For case 1, what is the EEG looking like now?
His EEG is much better now, though he is still having generalized discharges of sharp and slow waves, but is better than before. The cohotic background has been resolved, and he has multifocal discharges are still there.
Okay, and let's get back. So, what is your correlation between the seizures and the EEG? How much of the seizures improved? How much has the EEG improved? Say in percentage, because we are doing percentages. Seizure reduction by 70%, 60%.
Seizure has been reduced by about 70%, but the EEG's improvement is about 50 to 40%.
So that's something that I think all of us are seeing quite often, that when the seizures are reduced a lot, in fact some of them I've seen with no seizures at all, no obvious seizures externally, and internally the EEG is still fairly abnormal, and then that puts us on guard that we can't drop our guard so soon, because the parents are very, very anxious to, oh, let's get him off, can we get him back on normal food? So I think that's a very, very important point, Dr. Natasha, you brought up. The case 2 is about the child who lost weight and who was on topiramate. So one of the attendees, who is actually from Pakistan, Dr. Farida Jan, has asked that could topiramate have caused the reduced weight, and what is his height and IBW? He looks thin. I mean, there's no doubt he is below his ideal body weight. But if he's on topiramate, that could be the reason. That could be the cause.
Okay.
So what do you think?
But his height has improved, but he's on topiramate for the last 2 years, and his weight has been reduced for over a period of just 3 to 4 months. So parents are much concerned about why the child has reduced weight and is reducing weight on every follow-up on every month.
So the other thing is, have you looked at his thyroid function, made sure he's not?
No, I think we haven't went for thyroid functions. We did his renal functions, liver functions, but we will see for the thyroid function.
I think so, because that it could be that he has a high T3 or something. And you probably have to look at the free T3 and the free T4.
Okay. Could it
So
be due
that
to
is,
KD or not related to KD?
I don't
This
think it's related to the KD.
okay.
I don't think so, because if he's on the classical, or he's on the modified Atkins.
On classical KD.
Then I suppose you must have gone on increasing his calories, right?
Okay.
No,
Fine.
have
We
you
have
done that?
increased it, but we have increased his calories, but still the weight loss is the problem with him. So we will look for the thyroid function tests and
Is he feeling hungry? Because if he's losing
yes,
weight,
he is feeling hungry.
or that means you have to give more calories. I've seen this is something from experience. I've seen children of 2 and 3-year-old taking 2000 and 2400 calories a day, and they don't have any hormonal and endocrine problems. We've looked at that, and they didn't have anything, but they just ate so much, and only then they would start putting on weight again. So you'll just have to go on increasing the calories every time by 200 calories, and see how he goes until he is happy with how much food he gets, and then probably put on weight.
Okay, thank you.
There's another from you.
Case
What was
3,
the ratio of the KD in case 2?
case 3, in which the weight gain is the problem.
No, the question has been for case 2. What was the KD ratio in case 2?
4:1.
Okay, and only with that he maintains the urine ketone, is it?
Yes, he's maintaining urine ketone.
And have you been able to check the blood ketone at all, or we don't have
They
any idea?
are in the 2.5 to 3 ratio, millimoles per liter.
So that's enough. So probably you just have to go on increasing the calories sometimes I do it even every 2-3 weeks, until they really start putting on weight again. If
Okay.
he is not hypothyroid, he doesn't have any thyrotoxicosis, that's important. And the same question for you is, how about adherence of children's families to the KD? I'm not sure exactly what they meant.
I don't think this question is from me.
I think it is for you.
Okay. Adherence of the children. Sorry. Can you repeat the question?
They haven't said which one. Okay, so we'll just leave it at that. Bridgemeet.
Yes, sorry.
Uh, Question for Bridgemeet. How much ketosis is regarded optimal based on the BMI?
The ketosis is not really dependent on the BMI. This is very individualized for every child. Or whether he's going to get ketosis of 4 plus on a ratio of 2:1 or 2.5 or 3:1, that's very individualized to every child. BMI, that means our overweight child, underweight child, that is what we are looking at then.
Okay, so could you tell us something more about why you should get a child into the normal BMI range?
Yes, we could actually, talk on that. So there is a notion, a lot of people, parents are educated about this, that it is important to get the ketosis to 4 plus when the child is on his ideal body weight. At times, parents do think just adding ad lib fat and getting the ketosis to 4 plus is going to attain them seizure control. But only when the ketosis is 4 plus and the child is on his 50th percentile of ideal body weight. That is when he is going to burn his own body fat. Only when the child's own body fat is burnt, that is going to help attain seizure control.
Okay, I think that may be taken up in tomorrow in the fine tuning of the diet. The next question for you, Brijmit, is can we give fruit infused water?
We can give fruit as calculated as fruit.
So they've asked fruit infused water. I don't know what exactly it
Yeah,
means.
no, I get what they're saying, but we can give flavored water with the and essenced water with the flavors and essences which are available in the market. So you get the flavor of fruit, you get the essence of fruit that way.
And the next question for you, Brijmit, is while making bread, egg whites need to be beaten separately. How can this be done if the eggs are beaten up before weighing?
This recipe will categorically have egg whites calculated.
Okay,
When
correct.
white is calculated, then we weigh the amount of egg white which is calculated in the recipe. If the recipe says whole egg, that means we've got to beat egg white and yolk as a whole and then take the egg.
Okay, the next by Dr. Tipu is what could have gone wrong when you have urine ketones negative in the morning and large rest of the day? This is going to be taken up, Tipu, tomorrow.
Sir,
So when we talk about the fine tuning, the dietitian will be taking this up because this is something we see time and time again. Very often we see this morning ketones drop and then by afternoon, evening, night it's again better. So she will take this up in the next day's session. So I'll leave it to them. Does weight gain have an effect on anti-seizure drug? I think that is more for the
weight
doctors.
gain on anti-seizure drug. So
Yeah,
if
does the
weight
weight gain have an effect on the anti-seizure drug? Meaning, I think what they've tried to say is that if you are on an anti-seizure medication and you're gaining weight, and so then do we have
should
to,
increase the dose.
yeah, do
So
we have
this
to,
this was probably the question. I think
yeah,
if it is significant, then one must think about the increment in the dose because one should not wait for the day when actually a seizure occurred and then we may think that the serum level is well below the therapeutic level because of the significant weight gain. So probably we should maintain a therapeutic range and control the seizure.
great. So I think we've had a very good day's session. It's gone on for a long time. I think everyone is a little tired out. So I think we should call it a day. Tomorrow we will begin sharp at 9. We still have 94 attendees from the total of about 140 who came in. There are many, many more registrations, and I've been told that it's nowadays a fad that they take the registration. It's a fashion, I would say. Take the registration, and then they will get um, the recorded videos, and then they can see it at their leisure while they're in the car or when they're having free time, and therefore everyone doesn't necessarily have to come here. But I must thank all the faculty because it's been fantastic that we finished on time. This is one of the few times I think that a session has finished, in fact, a little earlier. 15 minutes in advance we've completed. So that's really very, very good. And thank you to all the faculty. Thank you to all the attendees because, I mean, this is one of the, I think, workshops where there have been a large number of attendees. I hope tomorrow being a Sunday, there'll be many more. Once again, thank you. Good day, good evening, good night. And some of you who are in the US, good morning. For some of you who are in Vietnam and Philippines, it's already night. So good night to all of you. And bye. Bye everyone.
Bye. And
We'll see
for
you
India and
tomorrow
Pakistan
morning.
is good evening.
Okay. Bye. We're ending the meeting and we're going to stop recording.
Thank you.
Thank you.